This is Scott Loveridge with the North Central Regional Center for Rural Development and Project Director for the Assessment and Education to Promote Behavioral Health Planning and Evaluation Program. And I'm pleased to be hosting this webinar today with Cassandra Joubert. Dr. Cassandra Joubert is Director of the Central California Children's Institute and Professor of the California State University, Fresno. She received a Doctor of Science degree in Maternal and Child Health from the Johns Hopkins University School of Hygiene and Public Health, and a Bachelor of Science degree in Psychology and Child Health from Harvard University. She's got interest in promoting the well-being of infants and toddlers through counseling and nurturing child-parent relationships, and training parents and practitioners who work with very young children. And she's the principal author of a family memoir that discusses racial and cultural influences on child development. Welcome, Dr. Joubert.
Well, thank you, Scott. Thank you so much for that introduction. And I am super pleased to be here to share the development of a program, a training program in infant mental health that was launched a couple of years ago here in the San Joaquin Valley of California. And I talk about this project as a practitioner-responsive project because it was really critical to us that we would get the input from practitioners, those working directly with children birth to 5 right now in the field, in designing and rolling this project out. So it's my pleasure to have been asked to share some of the steps that we took to develop the program and sort of where it is now. So I'll start by talking a little bit about the San Joaquin Valley of California and why this training is so important here. I'll include a few definitions about infant mental health for the audience, for those that are not so aware of this field, which is fairly new and still emerging. I'll take you through the 4 phases of project development, how we conducted our needs assessment, our project planning phase, and then, of course, implementation and evaluation. So just to start to talk a little bit about the San Joaquin Valley of California, there's a lovely picture here of, this is how the valley looks, the Central Valley of California, right dead smack in the middle of the state, landlocked. There is no water. It's a big issue for our region, which is the largest agriculture producing region in the country, if not the world. And if you see here, these the dark blue area of this slide shows the 8 counties that constitute the San Joaquin Valley. We have a population of about 4 million. And the region is largely Hispanic, 48% Hispanic. And it's a young region with about 30% of the population being between the ages of birth and 17. Educational attainment in the valley is a bit low relative to national statistics. About 14% of our population is college educated, and there are tremendous disparities by race ethnicity, with only 5.5% of our Hispanic or Latino population having a college degree. And the low educational level of our region is a real challenge in terms of regional prosperity, and a number of the issues that we are affected with here in the valley are reflected, or at least in part, in response to our low educational attainment. Our median income is about $26,000, also low for the state of California. And of course, as one would expect, there's tremendous variation by educational level. And our poverty rates. Probably poverty is the biggest challenge that we face. The Brookings Institution has identified Fresno, California in particular, which is right in the middle of the San Joaquin Valley, as one of the communities that has the highest concentrated poverty in the United States. And again, you can see racial and ethnic disparities in our poverty rates, with about 26% of our African American and Hispanic or Latino populations living at or below the federal poverty level. Child abuse and neglect is a tremendous issue here in the valley. The valley as a whole has about 11 cases per 1,000 children, substantiated cases of abuse and neglect. There are counties that are listed here along the right. Kern County, particularly high. This is on the south end of the San Joaquin Valley, down around Bakersfield. And also north of Fresno, up in Stanislaus County, we have as many as 14 cases per, substantiated cases per 1,000 children. So child abuse and neglect rates were a real impetus for developing the program, and I'll talk more about that as we move along. And as you would expect, given that we are a very young region in terms of age distribution, our child poverty rates are also high, with about 1/3 of our children living at or below the federal poverty level. I put this slide in asthma just as sort of a reflection of an indication of the overall health outcomes for children in the valley. Asthma is a really serious problem here because of air pollution in particular that is associated with our ag industry. In some of our counties as high as, let's see if I can use my little pointer here. In some of our counties we've got rates as high as 30%, 1/3 of children under the age of 18 are being diagnosed. There we go. They're being diagnosed with asthma. And overall, for the San Joaquin Valley, it's about 16.4%. So asthma is a real problem that's associated with absenteeism from school, emergency room hospitalization rates, etc. So I'll talk a little bit about how the project sort of got launched, and I want to take a minute to give some definitions about infant-parent mental health. What is it? When the term infant-parent mental health first started to be used in our region, the response was, so are you saying that children are born with mental health problems? And we really had to help people see sort of the range of issues, or the perspective from promotion all the way to treatment of mental health problems that infant mental health encompasses. So infant mental health is really healthy social and emotional development of children from birth to the age of 3. And as a field, it very much mirrors the public health field, which is it's devoted to the promotion of healthy social and emotional mental health, the prevention of mental health problems, and the treatment of mental health problems of young children. So it's a full range of practice. And who does it? Who are infant mental health practitioners? Well, this is what makes infant mental health so unique, I believe, is that it is fundamentally multidisciplinary. It is driven by the philosophy that anyone that has contact with a child between the age of birth and 3 has an influence on that child's mental health. So that could be early child educators in the child care setting, it could be nurses, speech and language folks, social workers, mental health professionals, early interventionists that work with children with disabilities, pediatricians, and others. And what do? Well, they perform a range of services that are relationship-based. When we talk about infant-parent mental health, we're really talking about the focus on the relationship, the strength of the relationship between an infant or toddler and his or her primary caregiver, which of course in most cases is the parent. So practitioners perform a range of services and supports that really promotes the healthy parent-child relationship that in turn would promote the healthy social and emotional development in the child. So how did we start this project? We launched it first with a regional needs assessment. We knew that there was significant new brain research out there that was saying that these first few years of life are so critical. We knew that there had been some initiatives in our region to support infant mental health, but they had not been sustained. Perhaps they were grant funded for a few years and then went away. So we knew that there was at least some understanding of infant parent mental health in our region, but we needed to get out and really determine particularly across the many counties that we wanted to work with, to what extent people really felt comfortable with the topic, what training was already going on. We wanted to identify who might be partners in this. We wanted feedback about how we should structure this training. Again, we wanted to emphasize those who are already out in the field doing the work, so what's going to work for them in terms of ongoing training and professional development. We were very intentional about increasing cultural diversity and competency in the workforce, so what would be appropriate strategies for accomplishing that. And ultimately our goal was to propose a model for the delivery of this infant mental health training that would be practitioner responsive and that people would really feel excited about and be and wanting to participate in. So as part of the needs assessment process, we convened a number of community conversations. We started with 3 counties in our region, and at those community conversations we asked basically, what do you know about this? How interested are you in it? We identified some champions that were already working in the birth to 5 arena that we thought would be viewed as leaders and could sort of be evangelists, if you will, and carry this message that this is important to undertake. And ultimately we wanted to develop some specific recommendations about what the training would look like and how we should proceed. We formed a steering committee of about 35 people. We did not handpick these people. It was wide open. We wanted you to, if you were interested in participating in the steering committee, we wanted folk to come forward. So we had about 35 people who met on a regular basis, anywhere from service providers to hospital reps, people who were not currently involved in infant mental health. And then we formed 3 committees, subcommittees of the steering committee, that would look at what is it that agencies that serve young children need in terms of professional development. That was called the Agency Training Committee. Curriculum, what's the content that they wanted, and also how could we build a pipeline? How could we develop a more culturally inclusive and competent workforce in infant mental health? And then out of that planning process, that needs assessment process, we developed a consensus document. And the bottom line recommendation was that we needed a community-based training program that would integrate the didactic, lecture sort of oriented kinds of training with opportunities to really reflect on what does all this theory mean, how do I translate this theory into practice. And so although we had a few academic training programs in our regions in infant mental health, we have a certificate program here at Alliant International University, and we have another satellite certificate program up in Napa, wine country, that's affiliated with the University of Massachusetts at Boston. Folks said, no, we need a community-based training program that is open and available to everybody. So we also hosted, as a part of our initial sort of testing the waters, we hosted a regional conference. We called this conference Nurturing the First Relationship, and we brought in Dr. Mary Claire Heffron, who is up at Oakland Children's Hospital, and she's the author of a textbook on reflective practice, and she does a good deal of professional development in this area. So then moving into the project planning and design phase, in addition to the steering committee, we thought we did need to handpick a few people to form a regional training council. And these folk represented the public agencies, public health, social services, offices of education, etc., that work most closely with young children. And they were instrumental. This team of about 15, 18 folk were really instrumental in actually designing what the training program would look like, the format, who the faculty would be. They were also critical, and I would say that this was probably one of our greatest successes, is that these folk actually did the recruitment of participants from their counties. And there was a very deliberate selection process, which I'll talk about more. But more than likely, I think I would say that without this training council being in place, we could not have attracted the quality of folk that we did, nor the numbers of folk that we did to participate in our training. And then once the training program was launched, the Training Council met on a monthly basis to troubleshoot logistical issues, of which there were many, and really helped us as staff work through all of those issues. So why the community-based training? I mentioned a little bit of this before. Just want to reiterate that it was important to us that no one that was interested in the field of infant-parent mental health have limited access. We wanted it to be open to folks all the way from the associate degree level in a community college all the way up to a PhD trained mental health clinician. Affordability was not really an issue for us because we were able to secure a significant grant from our Department of Developmental Services here in the state of California to support the training. It was important to us that this training be rooted in practice, so those who are actually doing the work in real time would be involved and engaged. It'd be multidisciplinary and, of course, be diverse, not only in terms of race and ethnicity, but we wanted rural, urban, we wanted male, female, we wanted to try to assure some parity, if you will, or diversity across all of those domains. So have to also mention that one of the things that California completed back in 2009, there was a work group that really defined training guidelines and competencies for folk who work with the birth to 5 population. So these competencies laid really the foundation for our training program. It took the mystery out of what did we need to include, how would we develop and shape out the curriculum. These are the training domains that those competencies state. Basic parenting and caregiving information, infant, toddler, preschool development, the impact of biology and psychosocial factors on outcomes, the role of risk and resiliency, some knowledge of the tools for observing the quality of the relationship, tools for screening and assessment, and then for those, of course, on the treatment end of the continuum, how do you diagnose and appropriately intervene when there are problems, and an emphasis on the importance of engaging multiple disciplines in treatment plans and in approaches to treatment, and then ethics. So the domains for our training were already specified through our state competencies, and our task was simply to align our faculty and our sessions to these domains. I want to mention reflective practice, which for those of you that have either a background in social work in particular or mental health, you'd be familiar with this concept, not particularly familiar in some of the other disciplines that we attracted to the program. But reflective practice is really a core element of infant mental health. It's not an add-on, it's not something that you do when you have time. It is really a fundamental element. During the reflective process in infant mental health, we encourage practitioners to really use themselves and their thoughts and feelings and how they develop relationships with others as sort of a parallel process for how that might be developed with a family that they're intervening with or working with. And so we felt it was important to give people opportunities to actually practice reflection as a part of this training. Also, reflective practice is required. Some training in reflective practice is required in order to be endorsed in infant mental health in our state. So trying to design a program that both offered lecture and didactics as well as reflection was not easy. We did manage to achieve it, and I'll talk a little bit more about that in a minute. So finally, in the planning phase, we also did conduct a regional training inventory. We also sort of knew from our community conversations and our needs assessment that not many folk in our region knew about some of the infant mental health concepts that are listed in our training guidelines. But we thought we should test that out so that we would have sort of some hard data on the extent to which people understood these domains. so we developed a survey tool, and as we suspected, comfortable knowledge about these domains was very low. So then project implementation. So after, I would say 2 years or so, almost 2 years of needs assessment and getting folks engaged in the conversation about infant mental health, we launched our Foundations of Infant Mental Health training program. Our first cohort was launched in 2012, and it was a 1 year. And then the second cohort was launched in 2013 and ended this past May. We designed our sessions such that there were 8, the entire program over the course of a year. There were 8 sessions, 1 session per month. The participants met for 6 hours in the morning, or rather 6 hours a day, and then 1 hour of reflective practice at the end of that day. We configured all the participants into reflective practice pods so that there were 20 pods of 8 people each, for a total of 160 participants in each cohort. And as I mentioned before, this design, having both the didactic and the reflective practice, allowed folks to collect hours towards their state endorsement in infant mental health in California. And this is just a list of the topics that we decided to focus on. The impact of early relationships on brain development was probably, the fundamental topic, and then layered onto that, we talked about the role of maternal depression and parental mental health on early relationships, how a child's sensory profile affects the relationship, and actually how the dyad's sensory reactions impact the relationship, the mother-child or the parent-child dyad. We focused on the impact of trauma and toxic stress on early brain development, the influence of culture, which was a huge request from almost all of our practitioners, that they felt that there was such a mismatch between the race, ethnicity of our providers versus the population that they were serving, and so they were really eager to get more information on how to navigate cultural differences, and then also multidisciplinary collaboration. How is it that the different disciplines need to team up and work together to better serve children and families? Our faculty were drawn from primarily folk in the state of California. This textbook, Infant and Early Childhood Mental Health, Core Concepts and Clinical Practice, was not released until about midway through our second cohort, but luckily a number of the authors and contributors to that textbook live in California, and we were able to engage them in our training program. So this is just a list: Dr. Christy Brad, Dr. Lillis, Barbara Stroud, Ruby Salazar, Josh Fader, just a few. Josh is a psychiatrist. Just a few of the faculty that we were able to bring into our program. And the way that we were able to assure that the faculty's presentations aligned with the state competencies is that we developed a curriculum grid that we sent out to each faculty person. We said, here are the training competencies for endorsement in infant mental health in the state of California. We are asking that you teach to these competencies, and we're asking that you tell us how much time in the course of your 6-hour lecture you will spend on each of these domains. You didn't have to spend time on all of the domains, but we needed to be able to track, for example, how much time they were going to spend on the topic of risk and resilience, because those hours, the calculation of those hours, was essential for those that wanted to then apply for state endorsement, because they had to have appropriate documentation of the time spent in each domain. So that worked really well. The faculty also submitted their learning objectives ahead of time, of course, and then we used those learning objectives to conduct a pre-test using SurveyMonkey and a post-test of each of the participants so that we could measure the change in their learning for those domains. And I mentioned reflective practice pods before, but I want to talk just a little bit about the deliberate process that we use to assign people to these pods. So once we had a person's application for the training program, we looked at what agency they worked for, what discipline they represented, what license they had, how many years in the field they had been in working with Birth to 5. And based on that information, we configured each of the reflective practice pods to be multi-county, multidisciplinary, and to also kind of be varied in terms of the level of experience that each of the participants had. We wanted the pods to really be rich, and so we configured them so that people could really learn from each other. And we had a facilitator that was trained in reflective practice that sort of led each of the 20 reflective practice pods through their conversations at the end of each training day. The recruitment strategy, I think, is also a bit unique. So one of the things that often happens in training programs is that those that have the money to participate, those that have the time from their supervisors to take the day to do it, those that tend to be higher up in organizations, or those that tend to be more attuned to announcements about training programs, those are typically the ones that sign up first and get the slots. And we really felt that because of the racial and ethnic diversity in our region, we really needed to make sure we had a diverse set of participants. So we actually developed a recruitment matrix. And this matrix actually identified the number of slots that we were willing to assign to each county based on the population of that county, and also based on the racial and ethnic distribution of the county. So you're not going to be able to read this slide particularly well, but I'll just say that across the top is the county and the population of the county. Along the left axis is the public agency. And then at the very bottom, we have the numbers in terms of racial, ethnic distribution in that county. And then we establish targets, racial, ethnic targets for each county based on this grid. I expected there to be a fair amount of pushback about this kind of approach. I suppose some people could say that this was sort of establishing quotas, if you will. But there was absolutely no pushback. People were completely comfortable with it, and we were able to meet our recruitment benchmarks very successfully. So I'm realizing I probably only have about 5 minutes left, so I'm going to move quickly through the project evaluation slides. Basically, we did meet our demographic goals. We ended up having about 51% of Latinos in our program, which is pretty consistent with our demographic distribution in the San Joaquin Valley. We did a really good job of getting representation from the various sectors, particularly the child care sector, which I was really proud of, because these are folks who often don't get a chance to participate in training opportunities this way. Our pre- and post-test scores were very good. This slide just shows, when you look at the light pastel colors, that shows the pre-test score across the learning objectives and domains that we established for each training. And then the dark colored bars represent the post-test score. So that was quite a nice increase in knowledge in each of the domains for each of the sessions. This is too small to read probably, but this is simply our overall evaluation where we ask people to rate the sessions on a scale of 1 to 5, 5 being the best. And along the bottom you can see that almost all of our sessions achieved at least a score of 4. The one that was slightly under was actually our psychiatrist, because so many people in the room said, you know, he talked a little bit at a higher level than they felt comfortable with, but overall we got very good, very positive scores on each of the training sessions. And then we also felt that as a result of this program, We definitely facilitated some collaborative working relationships across county and across agency. For the first time, we think people actually had an opportunity in a training session to take what the theory and principles were and how that applied, have conversations about application of those principles to their work. And at the end of the training, several folks actually moved forward using the hours that they had accumulated. I think over the course of the year, most people accumulated about 45 hours that they could use towards state level endorsement in infant mental health. And so at this time in California, the Central Valley actually has the highest number of people endorsed in infant mental health. And so that's a really huge success for us. We're excited that we don't have to stop with the Foundations program. That ended in May, but we've just gotten funding for a new project that will just focus on clinicians, licensed clinicians. It'll be a smaller cohort, 48 individuals a year, and we're going to be able to drill down more deeply into some of the content areas that we introduced during the first training program, focusing a little bit more on the impact of trauma, the impact of culture, looking at sensory issues as well as treatment modalities. And this time we're going to configure teams based on county. So instead of having multi-county teams, we will have county teams, so that people who tend to work together on a case or with a family that is touching multiple systems, those people will actually get to examine cases, think through treatment approaches as a team. And we're looking forward to this new project. This will launch in January of 2015. So with that, I just want to acknowledge our funders for the project, and also my email address here for those that may have questions later. Feel free to contact me. Thank you very much for listening.
Well, thanks very much. Is it project? Question I had related to, did a nice evaluation. Sound like maybe sessions. Have thoughts about coming back later, impact of licensing. What about capturing the changes in how folks work? How about
Yes.
immediately afterwards and do a resurvey?
Yeah, this is something we really wanted to do. We thought about perhaps 6 months out, like which would take us about now, or in September. I'm sorry, December, trying to reach out to those at least in the last cohort and say, okay, what impact did this training have on your practice? We just haven't had, honestly, the funding to do it. And also, it's a real challenge having so many disciplines engaged. On the one hand, we really wanted, that kind of diversity in our project, but when you think about that there's only a small number of clinicians that really are on the treatment end of the continuum, then you have a bunch of folks who are in child care settings that may have difficulty thinking about how that changed their interactions with families. We're kind of stumped about how to design an impact sort of evaluation that would cover the various disciplines and settings. So where we're landing is that after this advanced training, and most of the people that are entering the new training program actually took part in the foundations, that we would do sort of more of a cumulative impact evaluation with them at the end of this new program. The numbers would be smaller, but I think the approach would be more valid, because we'd be focusing on a slice, a homogeneous slice of folks that were in the program. So that's something we're struggling with. but hopefully we'll be able to figure it out and implement something that we can, that's actually usable going forward.
Well, I guess if I were doing it, I might just, given the population and all the different job descriptions, maybe just an open-ended, more of a qualitative.
Mm-hmm.
Just go back and send them an email saying, you had this training 6 months ago, and could you tell us what's different now? How are you approaching your work differently?
And maybe use some of that fancy qualitative software that pulls themes out, right? Pulls themes out, and I mean, that would certainly be one way to do it, and then we could report it out and look at differences sort of by, the setting that they work in or the discipline that they represent, that kind of thing.
Yeah, you can kind of classify it after the fact, or classify it by job description, and I think that'd be interesting, because you might find that in some of my earlier work, I always was a little hesitant to go back 6 months later and ask what happened, and I was always pleasantly surprised.
Well, exactly. And I one of the things that excites me about this work is how passionate folk are who work with young children. I mean, it's a calling for them, and so they seem to be so attuned to how they can improve the way that they deliver services. And so I do feel confident that if we went back and asked them that question, they would have some really clear reflections and observations about the difference that it made. So, okay, Scott, you're hired as our new consultant on evaluation to help us do this. Let's talk.
So Courtney is having some audio issues, so she wanted me to share with you this question. Loved your talk, and the project's very interesting. And you started out talking a little bit about the poverty issues in the valley. And so she wants to know, how does poverty affect infant mental health in the valley, and then how does it also affect efforts to improve infant mental health?
Excellent. Well, we think that one of the most significant ways it affects infant mental health is maternal depression, because Hispanic women in our region have higher rates of maternal depression than other populations. And we think that is in large measure due to the fact that we have a lot of families that migrate here from Mexico, and often, the father comes first, and then the family comes later, but then the father is in the fields working. They're isolated from their, traditional sort of family clan, if you will. They don't speak the language. They, are suffering in terms of economic resources. And it's just one stressor piled over the other, for these families. And so when the parents are depressed, it has a huge impact on the quality and the nature of interaction with a young child. And so the relationship, the attachment, the bonding, also just the stimulation, of the young brain is limited because of those factors. So that has a huge impact on infant mental health in our region. And in terms of improving infant mental health, I think that having the public agencies on board for this project, public health, social services, county offices of ed, our disabilities agency, having those large agencies who work with these populations so closely involved, they have come away with sort of a renewed commitment to helping the families support early relationships as a result of the training. I I think that it's fair to say that every caregiver wants absolutely the best for their child. So some of the change that we would like to see happen can come about through greater awareness and education with these young moms. Maternal education level is a barrier. We know that the lower a mom's educational level, the higher the risk of abuse and neglect. But that simply gives us good data and good feedback in terms of populations that we target with this information. So I'm hopeful that we're going to be able to do a better job going forward of really reaching those who need this information the most.
I've got a little follow-up, and Courtney has another question too, but those special needs populations where poverty is high, there's also often, as you sort of alluded to, time constraints where they're long days, multiple jobs,
Mm-hmm.
really have their stress for time as well as the other stressors that associates with poverty. So how do you get that population to be ready to receive the kinds of services that we're talking about? Or how do you catch them
Mm-hmm.
when they're time stressed?
So we have developed a cadre of promotoras, community health workers in our region that are working with families on a number of different health issues, obesity, diabetes, substance use, etc. We think that the promotora model is an effective one for reaching families. Many of the agencies that work with young children have a cadre of outreach workers that can connect with families after hours, create sort of a supportive environment, whether it's in a local church or neighborhood setting to reach families. We even have a van that one of our local funders has provided to actually go into the rural communities and around the region to promote breastfeeding. So we try everything, but we do think that using cultural brokers, promotoras, health navigators is a key strategy. And these folk have to be from the communities that they are working with, and they have to be prepared to work after hours. Typically the field worker goes out in the wee hours of the morning, maybe even before sunrise, starts picking the crop, and then by 2 or 3 o'clock in the afternoon, when it gets super hot, they're heading back to their community. So the real work starts, and the real opportunity to work with families is like 3 p.m. and beyond. So it requires a lot of commitment and a lot of willingness to do things differently to reach the families that need the services. But those are some of the strategies we're trying here.
Great, excellent. So sounds like you've got some workable methods for doing that. Courtney's question was, what do you recommend to communities who may be interested in improving infant mental health? What kinds of low-cost programs or initiatives are out there that seem to be effective in your mind?
Well, we are just really starting to look at some models. There's one that we're especially interested in that is a parent, I think it's called, it's sort of like a parent resource center model in communities where you have neighborhood-based hubs of information and support groups that would encourage greater interaction between parents and young children. We're looking at that because we already have established family resource centers sort of sprinkled through our region. And so if there's a way to add this component that would just be focused on relationship enhancement between parents and their young children, we think that can work. We also have thought about going to traditional entities that serve low-income families, like the WIC office or the Federally Qualified Health Center, and thinking about how we could provide resources maybe in the form of an individual or information, videos, other materials that we can sort of do a very targeted public awareness campaign for our families. But this is sort of a new this is a new arena. This is a new field that we don't know of many communities that have these models in place. So we're in the process of examining what's out there, which isn't a whole lot, and trying to develop some models.
Here's another question, and forgive me for bringing my economist bias to this, but these are real issues, and they have long-term consequences. The costs are, potentially quite great for not addressing these issues, and at the same time, a lot of our local decision makers are, kind of focused on, their own fiscal cycle and making, kind of some inroads and being able to point to successes between now and the end of the fiscal year. And so how does one sort of gain the attention of a policymaker for something that is important, has a huge impact on society, but a lot of that impact is going to be felt, kind of further in the future?
Yeah, I mean, that's the challenge we've had. I've been doing child advocacy work for, 30 years, and that's the challenge that we have. I mean, we have the data that says, for every dollar you invest in quality preschool, you save $4 on the other end. And, juvenile arrest rates, teen pregnancy, welfare dependency, etc. We have the data, and we have the cost-benefit analysis. I mean, all that's sort of been done. But unless you find a champion within the state, I mean, it's almost like you've got to get a policymaker in the room, take them to the Harvard Center for the Developing Child's website, which has these many videos about brain architecture and the importance of early relationships and the impact of toxic stress on the young brain. Show them this 3-minute video, give them some very specific ideas about investments and how they're likely to yield success, and that's the part that we're working on right now as it relates to mental health anyway. And hold their feet to the fire. I mean, it's a tough process, but typically you only get 1 or 2 champions like that. In California, we've got some folk who are really committed around the issue of autism, and we have some folks that are really committed around issues of equity. So, those would be 2 great legislators to go and sit down and kind of share this information with if you can get your foot in the door. But I think that it's, the problem of political will has been a problem, a long-standing problem, and it continues to be a problem. I'm not sure if I just learned this year that the Institute of Medicine had published a report on the prevention of mental illness, and here I am, I'm in the field, and I just got my hands on this report. And then I also learned this year that Georgetown University had published a report on called a public health approach to children's mental health. And so thankfully at the national and federal level, there are these new resources that are coming down that will help us when we engage with policymakers. And we've got more and more consensus reports and expert panels that are pulling this information together that we can use for advocacy. But it takes a long time for this stuff to trickle down because, like I said, I've been in the field for I don't know how long, and I just learned about a couple of these this year. So the fight continues, the struggle continues.
Yeah, and of course, I don't want to beat them up too much, the policymakers, because they have their own constraints, but it's an issue that plays out over and over again, and ultimately we all pay the price.
Right.
For not looking ahead.
That's
So,
right.
well, great, wonderful set of ideas shared today. I thank you very much for sharing this, and I think it's a useful set of programs that you're engaged in, and I look forward to hearing more in the future.
Well, it's certainly my pleasure. Thank you so much for asking me to do this. I think this helps us get the word out about this science and the importance of it, so I appreciate very much the opportunity.
Okay, thanks much.
Thank you, Scott. Rosa, Courtney,
Thanks, Scott.
thank you all.
All right.
Signing off now.